The value of preoperative 3-dimensional over 2-dimensional valve analysis in predicting recurrent ischemic mitral regurgitation after mitral annuloplasty. A study of the Gorman Cardiovascular Research Group, in collaboration with the University of Pennsylvania, University Medical Center Groningen, Harvard Medical School, Stanford University and the University of Pittsburgh. The authors have nothing to disclose with regard to commercial support. The central message of this study is that preoperative 3D P3 tethering angle is a much stronger predictor of IMR recurrence 6 months after annuloplasty than preoperative 2D posterior tethering angle, which is highly influenced by viewing plane selection. In patients with a preoperative P3 tethering angle of 29.9 degrees or larger, especially when combined with the presence of a basal aneurysm or dyskinesis, chordal sparing valve replacement should be strongly considered. Ischemic mitral regurgitation is common and strongly affects prognosis, with a graded relationship between severity and reduced survival. Mitral valve repair with undersized ring annuloplasty has been the preferred treatment for AMR, but IMR recurrence rates remain high, more than 30% after 6 months. Undersized annuloplasty can potentiate leaflet tethering, which may explain high IMR persistence recurrence rates, and the inability to demonstrate a survival benefit of annuloplasty for AMR. The CTSN multi-center, randomized trial, among 251 patients with severe AMR, who underwent annuloplasty repair, or chordal sparing valve replacement, showed no difference in LV reverse remodeling, MACC, functional status, quality of life, or survival 1 year after surgery. And that IMR recurrence was significantly higher 1 year after repair, 32.6% after repair, versus 2.3% after replacement. Patients with IMR recurrence after repair showed no LV reverse remodeling, indicating advanced stages of tethering. A patient-specific, preoperative, imaging-based approach to repair for AMR is required to optimize results. 2DE studies on preoperative predictors of IMR recurrence show inconsistent and sometimes conflicting results, which highly depend on viewing plane. The objectives of this study were to determine if the degree of preoperative tethering determines IMR recurrence risk, and to determine if preoperative 3DE provides stronger predictors of IMR recurrence than preoperative 2DE. In this study, 50 patients with 3+ or 4+ IMR underwent undersized ring annuloplasty. As a reference, we also included 21 patients with normal mitral valves undergoing other cardiac procedures. Patients underwent transesophageal 2D and real-time 3D echocardiography. A custom valve modeling algorithm was used for quantitative assessment of annular geometry and regional leaflet tethering, followed by assessment of IMR recurrence with 2D TTE 6 months after repair, and assessment of the ability of annular geometry and regional leaflet tethering to predict IMR recurrence with univariate and multivariate analyses to single out independent predictors, 3D versus 2D. Shown here is a 2DE geometric analysis of the mitral valve in the 2-chamber and the 4-chamber views. It is important to note that these views cut across different sections of the mitral valve, as shown in C and D. Determination of annular diameter, tethering height, and tethering area in the 2-chamber view are shown in E. Determination of anterior and posterior tethering angle in the 2-chamber view are shown in F. Shown here are our custom 3D annular and leaflet segmentation techniques. Shown in A, on the upper panel, is a 3D echocardiographic volume containing the mitral valve with cross-sectional planes at 10-degree increments. Shown in B, in the upper panel, is a representative 2D cross-section with green dots representing the selected annular points. Shown in C, D, and E, in the upper panel, are oblique, intercommissural, and transvalvular annular views, of a single, real-time, 3D-derived mitral annular model, with annular landmarks, and the 36 annular data points. The circles shown are determination of septolateral diameter, intercommissural width, and mitral transverse diameter. These figures are also used to determine mitral annular area and mitral annular circumference. Shown in A, in the lower panel, is a template of transverse cross-sections, every 1 mm, along the intercommissural axis. B and C, in the lower panel, show one of the 2D cross-sections, represented by the white dashed line in A. Determination of mitral valve tethering area, anterior and posterior tethering angles, are shown in B and C. These figures are also used to calculate mitral tethering volume, mitral tethering index, and segmental, mean, tethering angles. On the left, a 3D rendering of a normal mitral valve after image segmentation. On the right, a 3D rendering of a severely tethered ischemic mitral valve after image segmentation. A total of 13 patients, 26%, experienced recurrent IMR 6 months after undersized annuloplasty. Based on these findings, patients were divided in recurrent and non-recurrent IMR groups. Preoperative degree of IMR, LV size, and LV ejection fraction were similar in the non-recurrent and recurrent IMR groups. The basal aneurysm or dyskinesis rate was significantly higher in the recurrent IMR group compared to the non-recurrent IMR group. Intraoperative patient characteristics were similar in recurrent and non-recurrent groups. Preoperative 2D annular diameter was similar for recurrent and non-recurrent groups in the 2 and 4 chamber views. Preoperative 2D tethering height, tethering area, and anterior and posterior tethering angles were significantly higher in patients with recurrent IMR, but only in the 2-chamber view, and not in the 4-chamber view. Univariate and multivariate logistic regression analyses revealed preoperative posterior tethering angle, measured in the 2-chamber view, as an independent predictor of IMR recurrence after undersized mitral annuloplasty. A ROC curve was calculated for preoperative posterior tethering angle to single out the optimal cutoff value of predicting IMR recurrence. The optimal cutoff value was 32.0 degrees, with an area under the curve of 0.81, a sensitivity of 90.9% and a specificity of 61.1%. Preoperative 3D annular parameters were similar in the recurrent and non-recurrent groups. Preoperative 3D mitral valve tenting index and preoperative tethering angles of A3, P2, and P3 were significantly higher in patients with recurrent IMR. Univariate and multivariate logistic regression analysis revealed preoperative P3 tethering angle as an independent predictor of IMR recurrence after undersized annuloplasty. When the functional parameter, basal aneurysm or dyskinesis, was added to the geometric 3D analysis. Multivariate analysis revealed preoperative P3 tethering angle and basal aneurysm or dyskinesis as independent predictors of IMR recurrence. A ROC curve was calculated for preoperative P3 tethering angle to single out the optimal cutoff value of predicting IMR recurrence. The optimal cutoff value was 29.9 degrees with an area under the curve of 0.92, a sensitivity of 84.6% and a specificity of 89.2%. In this figure, the incremental value of preoperative 3D over 2D echocardiography in predicting IMR recurrence after mitral annuloplasty becomes apparent immediately. The incremental predictive value is represented by the orange area. In this figure, the incremental value of the combined model over preoperative 3D geometrics in predicting IMR recurrence after mitral annuloplasty becomes apparent immediately. The combined model generates an area under the curve of 0.94, and the incremental predicted value of the combined model is represented by the red area. Mitral valve repair with undersized mitral valve annuloplasty for IMR is consistently characterized by an IMR recurrence rate of approximately 30% after 6 to 12 months, 26% after 6 months in this study, and 33% after 12 months in the CTSN trial. Undersized MVA can potentiate leaflet tethering in patients with more severe tethering, but in patients with less advanced tethering who do not experience recurrent IMR, undersized MVA may offer benefits over valve replacement, especially with regard to LV remodeling and function. A patient-specific approach to treatment, guided by preoperative, imaging-based risk stratification, that is predictive of recurrent IMR, is useful to optimize results. Such an approach would allow patients with a high IMR recurrence risk to have valve replacement, while low-risk patients would continue to receive repair. 2D echocardiographic studies identified different predictors of IMR recurrence, but results are inconsistent, often non-reproducible, and sometimes conflicting. The study shows that 2DE can predict IMR recurrence, but results are highly dependent on viewing plane selection, 2-chamber versus 4-chamber view. 2D preoperative posterior tethering angle, in the 2-chamber view, is an independent predictor of IMR recurrence after undersized ring annuloplasty with an area under the curve of 0.81. 3D preoperative regional leaflet tethering of P3 is a much stronger independent predictor of IMR recurrence after undersized ring annuloplasty, with an area under the curve of 0.92. Adding the functional parameter basal aneurysm or dyskinesis to the multivariate 3D geometric model yields an even stronger predictive model of IMR recurrence with an area under the curve of 0.94. Real-time 3D echocardiography combined with a custom valve modeling algorithm is a much more powerful tool to quantify the complex mitral geometry and to predict IMR recurrence. Real-time 3D echocardiography overcomes many limitations of 2D, such as viewing plane selection and regional distortions, but still requires time-consuming analysis, although rapid automated image processing is under development. 3D echocardiography will complement direct valve analysis in the OR and help direct surgical intent to either valve repair or replacement. In patients with IMR and a preoperative 3D EP3 tethering angle of 29.9 degrees or larger, especially when combined with the presence of a basal aneurysm or dyskinesis, chordal sparing valve replacement should be strongly considered. These predictive models require further refinement and validation in larger, future studies. The central message of this study is that preoperative 3D P3 tethering angle is a much stronger predictor of IMR recurrence 6 months after annuloplasty than preoperative 2D posterior tethering angle, which is highly influenced by viewing plane selection. In patients with a preoperative P3 tethering angle of 29.9 degrees or larger, especially when combined with the presence of a basal aneurysm or dyskinesis, chordal sparing valve replacement should be strongly considered. This study was funded by several grants from the National Institutes of Health. This study was brought to you by the Gorman Cardiovascular Research Group in collaboration with the University of Pennsylvania, University Medical Center Groningen, Harvard Medical School, Stanford University and the University of Pittsburgh. Thank you for your attention.